Okay, so this is a journal club presentation by myself and Lucy. We were reviewing the sub-ICU paper for, next slide please, Lucy. For the pantoprazole in patients at risk of gastrointestinal bleeding in ICU. Can everyone hear me? Next slide, please. Thank you. So, for a general background, patients who are in ICU, who come to ICU, are generally at risk of gastrointestinal bleeding from stress-related ulcers, and usually associated with adverse outcomes. Previously, studies have shown that approximately 17% of patients admitted to ICU suffered from a GI bleeding if they received no prophylaxis, and of the treatments available, the most commonly used are proton-pump inhibitors. However, there is limited evidence for the use of PPIs in stress ulcer prophylaxis, and also there have been concerns raised about the side effects that occur as a result of stress ulcer use, of PPI use, and questions about whether or not the benefits outweigh the risks. Next slide, please, Lucy. Thank you. So, in terms of risk factors for stress ulcer occurrence, there's shock, and use of anticoagulant agents, renal replacement therapy, mechanical ventilation lasting over 24 hours, any history of liver disease, and any history of acute or chronic coagulopathy. Next slide. So the aim of this paper was to assess whether pantoprazole reduces mortality in comparison to the placebo in patients at risk of GI bleeding, and reduces mortality at 90 days. The hypothesis was that pantoprazole would be associated with a lower rate of gastrointestinal bleeding but a higher rate of infections and myocardial ischemia than a placebo in high-risk ICU patients. So they did this using a multi-centered stratified parallel group placebo-controlled blinded clinical trial, where they involved over 3,000 patients over a 21-month period across 6 countries, and 33 ICU units within those countries. Patients who were admitted to the ICUs were screened by clinicians there to see if they're eligible. The inclusion criteria was that patients were over 18 years old, admitted to medical and surgical ICU for an acute condition, so not for elective admission, although some elective patients were chosen if they had acute complications, and they had one of the aforementioned risk factors. The exclusion criteria are just contraindications to PPI, receiving acid or filtering therapy, diagnosis of peptic ulcer disease, pregnancy, organ transplant, and withdrawal of active therapy. So, next slide, please. Thank you. So, once the patients were chosen, they were randomized in a centralized computer system and stratified according to trial site and presence of hematological cancer. Patients who were eligible were then randomly assigned and given in a 1-to-1 ratio between placebo and pantoprazole. And the assignments were blinded from everyone involved, including patients, clinicians, investigators, statisticians, members of the Data and Safety Monitoring Committee as well. And what happened to the patient was they were either given pantoprazole 40 milligrams IV with sodium chloride bolus, or a matching placebo as a single bolus once a day until ITU discharge or death for a maximum of 90 days. Those who came back within the 90-day period continued the regime they were initially on. Next slide, please. Thank you.
Okay.
So the primary outcomes measured were death after 90 days, and secondary outcomes were clinically important events such as infections, myocardial ischemia, GI bleeds within those 90 days.
Okay, I'll take it from here. So the results, what we want to know. So the primary outcome measure was the 90-day all-cause mortality, which showed a 31.1% versus a 30.4% mortality in the two groups, with a p-value of 0.76, so not statistically significant. And then patients having one or more clinically important adverse events, so the GI bleed, pneumonia, C. diff, or acute MI, showed a slightly reduced incidence in the PPI group, so 21.9% versus 22.6% in the placebo group. But there was no p-value for this, and this kind of went against the hypothesis that the actually no, ignore me, don't worry. And what we actually want to know, the GI bleed, so this is why we're doing it really. So they defined a significant GI bleed as overt bleeding plus one or more of a drop in any parameter of blood pressure of over 20 millimeters of mercury, a new vasopressor requirement, or a 20% increase in an existing vasopressor dose, a hemoglobin drop of over 2 grams, or a 2-unit or more transfusion. And they found that 2.5% of the patients in the PPI group had a significant GI bleed versus 4.2% in the placebo group. So on the face of it, that looks potentially interesting because that's why we're doing this. And looking at the other clinically significant events, so they kind of grouped pneumonia and C. diff together as infections, and they had roughly the same incidence in the two groups. And they also looked at days alive without the use of life support, so ventilatory support, and that was the same for both groups as a median days. And they also reported no serious adverse events in either group. So from that, they concluded that there was no significant difference between pantoprazole and placebo within 90-day all-cause mortality, or the number of patients with one of the 4 clinically important events. So, however, there was clearly a non-statistically significant reduction in GI bleeds, which is of some interest. And I've seen an analysis done after this paper, which showed that a number needed to treat based, if we take it as statistically significant, which obviously isn't on data analysis, but we sometimes like to believe that things will help. The numbers needed to treat would be 59 patients treated with pantoprazole to prevent one significant GI bleed. So just a very quick look at the paper. So obviously it was published in the New England Journal of Medicine, which is a well-respected journal. So there was a large number of participants enrolled over a relatively long period, multiple centres, multiple countries, and there was appropriate randomisation and blinding. And something that I liked was there's a huge list of grants from pharmaceutical companies, like half an A4 page of all pharmaceutical companies that fund the investigators, not necessarily for this paper, but still. And I like the fact that they reported that there was no there was no statistical difference, which often doesn't happen. However, there was quite a broad inclusion criteria, which could be seen as a weakness or a strength. I guess we have a very broad set of patients, so actually this is relevant for most of our patients. but there was no acknowledgement of confounding factors. And also, I thought it was a little bit strange that there was no p-value for secondary outcomes. I guess because there wasn't a significant difference in the incidence of GI bleeds. So yeah, any questions? No? Anyone still there?
It was standard. 40 milligrams. So she asked what dose was used for pantoprazole.
40 milligrams IV, which is obviously what we use in the unit.
How do you think this would change your practice now?
So I don't think it would change my practice. Obviously, where we work, we do give PPI treatment, given despite kind of scarce evidence, but I think all the research that I've seen on similar topics shows a weak correlation between reduction of GI bleeds and PPIs. So I guess we'll just continue to do what we do. I don't know what you think, Jack.
I know that PPI prescribing is pretty much a standard, and I think that the mortality difference that you've presented there, it doesn't necessarily quantify the sort of secondary effects of PPI prescription. So you would want to know in detail, wouldn't you, about pneumonias and C. diff infections as a comparison, because it doesn't seem as though our practice of prescribing almost routinely is particularly warranted based on that paper.
Yeah, I agree. And I was quite surprised.
It was good. Thanks for that.
Yeah, that was very good. Interesting.
Any other comments?
Hold on, we've got one here. Hold on.
Yeah. Lucy, can you hear me?
Yeah.
So I was wondering if there's any other papers comparing like omeprazole, pantoprazole, and other drugs, lansoprazole, with the primary outcome which you measured here, like a 90-day mortality. Was there any other paper comparing different drugs?
I'm not sure, to be honest. I think that this paper kind of came up with its own secondary outcomes that were quite non-standard, so I think it'd be quite difficult to compare. But in terms of mortality and GI bleeds, I'm not sure. I think Samaya did a journal club a few months ago, looking at PPI versus ranitidine. I think which showed no difference between those drugs.
Cool, thanks.
Any other comments?
Lovely. That's great then. Thanks very much, Lucy.
Okay, thanks everyone.
Awesome. Cheers, guys.
Right.